Hello, everyone, and welcome to Behind the OR, the Peter Surgical Podcast channel, where we invite experts to reveal to us what's happening behind the closed doors of the operating room. Together, we will explore surgeries and procedures and discover more about a surgeon's life in their daily mission. Take off your gloves, take a breath, and let's talk behind the OR.
The value of robotic coronary surgery in the current era of bypass grafting. Good morning, everyone. My name is Gianluca Torregrossa. I'm a cardiothoracic surgeon who practices in Lankenau Heart Institute in Philadelphia, United States of America. My deep passion is coronary artery bypass grafting, and I perform every type of surgery to treat patients with coronary artery disease. I perform sternotomy bypass with a mammary and two veins. I perform impel-assisted CABG, off-pump coronary bypass grafting, total arterial with bilateral internal thoracic artery, radial artery, and gastroepiploic artery, and I perform minimal invasive robotic bypass surgery. In the mid-90s or late 90s, the coronary artery bypass grafting was trying to figure it out its own role, while the percutaneous coronary intervention, the stents, were growing in number and were easier to be performed. In this sense, surgeons and a group of surgeons started to perform robotic bypass grafting, a form of offering one or two bypasses performed with the two internal thoracic arteries via a keyhole access in the left chest of the patient. This bypass was meant to be a competitor of the percutaneous coronary intervention, but was itself a complex procedure that required a very highly technical skills from surgeon to be performed. In that time, in that matter, cardiac surgery was not ready. That generation of surgeon was not ready to adopt the robotic setup in their operating room. And in fact, only few pioneers have kept practicing robotic cardiac surgery and particularly robotic coronary surgery. The value in the current era, though, is growing in evidence. Robotic bypass can allow to treat patients with the best graft that is a lifetime investment for that patients in the long-time management of coronary artery disease. That graft is the left internal thoracic artery to the left anterior descending coronary artery. We have growing the interest to treat patients with this type of bypass in association or not with stent for the non-LAD territory, providing a hybrid revascularization that allow patients to have a sternotomy spare approach and return to their own normal life in a better and more functional way. More important, even in the latest and current generation of percutaneous coronary intervention and stent, we have noticed that the incidence of in-stent restenosis, the risk associated with in-stent restenosis, and the problem of frequent needs to go back to clean up the in-stent restenosis can severely impact the perceived quality of life in the long term of patients with coronary artery disease. And more important, they can change the outcomes of survival and overall ability of that left anterior descending artery to be the best target, the best coronary target that supply the 60% of the mass of the heart. In this sense, in patients with discrete proximal lesion of the LAD, even if they are in advanced age or in a very young age, robotic coronary bypass grafting offered the opportunity to treat with the best conduit, with the best strategy, the Lima to the LAD, any patients that comes and get approach and needs this type of surgery. The surgery has been conducted via 3 small incisions in the left side of the chest, and in the most current era has been conducted using a small thoracotomy to perform the connection of the 2 arteries together using directly a hand-sewn technique. Further advancement, and our team has showed and described a technique to perform a totally endoscopic bypass surgery, TCAB, that allow the surgeon to perform the distal anastomosis in a complete closed environment. The value of TCAB are not only aesthetic. The lack of a thoracotomy allow the surgeon not only to offer a complete painless-free experience to their own patients, but they can also offer the possibility to complete more than one bypass surgery. Robotic mid-CABG, meaning the procedure that requires the thoracotomy to connect the 2 arteries, is mostly limited to treating the anterior wall with one single bypass grafting. TCAB instead has the opportunity to allow the surgeon to reach any coronary target, including the posterior wall, the inferior wall, and the lateral wall. In this sense, constructing enough pump, the use of 2 mammary artery and a Y graft, a surgeon can offer 2 or 3 bypass in a complete closed chest using the best conduit offered for the treatment of coronary artery disease, the internal arterial grafting. There is a need of a new generation of cardiac surgeon interested in coronary artery bypass grafting, a super specialization of dedicated and skilled surgeon capable of offering any type of surgery for their own patient. Robotic coronary bypass and TCAB are not in fact here to take patients off from the operating room or away from receiving a sternotomy bypass, but mostly compete against percutaneous coronary intervention to avoid the risk associated and the long-term poor outcome associated with multi-vessel percutaneous coronary intervention. Moreover, when a patient in my practice has an age above the age of 80 and comorbidities that do not allow him to recover easily from a traditional sternotomy bypass grafting, including poor mobility, previous joint surgery, patients with walker, patients with oxygen supplement, the opportunity to perform a closed chest surgery increase the chance of a safe procedure that can help patients. So it's extremely important to educate a next generation of surgeon in adopting the robotic platform to take the 1 or 2 internal thoracic arteries and perform multiple bypass in a complete closed chest. This is the holy grail of every coronary surgeon, multi-arterial, TCAB, robotic, a surgery that is clean, where the hands of the surgeon are not within the chest of the patients, there are no incision, there is no thoracotomy, and we minimize the risk of stroke by performing what we call an aortic bypass grafting, a surgery where the 2 mammaries are the source of the blood for the bypasses and the aorta is not touched. The technical difficulties of robotic needs a dedicated training. They need a new generation of surgeons interested in this type of procedure, but also need a generation of companies and industry that are excited to come back into the field of cardiac surgery with their robotic platform or their technology and developing new techniques, new technology that help surgeons to streamline, to simplify a procedure, TCAB, the total endoscopic bypass, that at the current time is still very technical demanding. I've personally performed in the last 2 months more than 12 cases of TCAB with an extreme success, and most of the patients has been discharged within 1 day after surgery. So a complete shift in paradigm in what we can offer to our own patients. This is the way, this is the leading direction. We need to implement technology, education, and surgeon interest in the discipline of robotic coronary surgery. Thank you so much for your attention today, and looking forward to take any question that you have.